Anne is a 63-year-old female who's been diagnosed with arthritis in her knee. Lately, her arthritis has become so bad, it's preventing her from sleeping night after night. She took two over the counter pain pills per day, but the pain was still waking her up at night, and the drugs were hard on her stomach. She's been talking with her doctors about alternative methods for her pain management, one of which was cannabis. Chronic pain, which is pain that persists or recurs for 3 months or more, affects nearly 20% of Canadians daily. The odds of living with chronic pain increase with age, with women being more likely to be affected than men. So called medical marijuana has been available for a while. Since the legalization of recreational cannabis in Canada, there's been renewed interest in the potential medical uses for cannabis, particularly for managing chronic pain. We've asked Dr. Jason Bussa to talk about the use of medical cannabis to assist with the management of chronic pain. Dr. Bussa is the Associate Director of the Michael G. DeGroote Center for Medicinal Cannabis Research. His primary research interests are in chronic pain and in evidence-based clinical practice. Welcome, Jason. Great to have you today.
Great to be with you.
So let's start out by asking the question, how exactly does cannabis work to relieve pain?
It's a great question, and the short answer is we're not sure. Cannabis is unlike traditional medications in the sense that it's a plant. So there are there's over 100 active cannabinoids within the plant itself. The two most commonly studied cannabinoids are THC and CBD. THC is psychoactive, meaning it causes the high, that euphoric feeling that people will use cannabis for recreational purposes. So that may help in distracting people from their pain. CBD does not have psychoactive properties. It is not used for recreational purposes, but it does appear to have a number of other effects, including fairly reasonable anti-inflammatory properties, which might help explain some of the effects that it could have on symptoms of pain.
That's interesting. And I guess there's quite a few different formats that these medications or medicinal cannabis can come in. Is that right?
Yeah, you're absolutely right. Health Canada keeps track of the kind of formulations that adults in Canada that have been authorized by a provider to use cannabis therapeutically are acquiring. For the most part, these are dried flower products. And so these would typically be taken in either through smoking or through vaporizing. But more commonly or increasingly commonly, we're seeing sprays, we're seeing oil drops, oil-filled capsules, even topical preparations. I've even seen some ads for suppositories.
Research on cannabis has been a little bit late to the party, but you've been really involved in it. Can you talk about some of the research surrounding the use of cannabis for chronic pain?
Yeah, so cannabis is an interesting component as a therapeutic agent. Traditionally, what happens is Health Canada will receive evidence, ideally from randomized clinical trials, establishing the benefits and harms of a therapy, which they evaluate. And if the net benefit is supportive, they will authorize that product for therapeutic use. Cannabis has not come onto the market in a similar way. It has largely been authorized initially on the basis of compassionate grounds, through changes to our legal, our laws and our legislation. And now research is having to play catch up in a sense to find out what are the benefits and harms of this product that's now widely available. It's complicated as well because in 2018, Canada became the first G7 country to legalize cannabis for non-therapeutic use. So now you have very similar products out there being used for therapeutic use, for recreational use. You do not have to have a burden of evidence to sell recreationally, but patients are acquiring these products and using them for therapeutic purposes. So we do have some evidence, but we need a lot more.
Lots of, lots of N of one trials. I mean, as you say, chronic pain patients can access recreational cannabis now, but even for years on compassionate grounds, I've worked with a lot of patients with cancer or nerve or muscle diseases that have been accessing cannabis either because it's authorized or not. And chronic pain is a really common condition affecting about 20% of Canadians. What are some of the research studies that are coming out saying, and I guess you've been directly involved in looking at both the quality of the research as well as what the findings have been so far?
Yeah, what we noted was there was a high variability in the guidance that was out there. Unfortunately, this is a topic that comes up during undergraduate medical education. We've done qualitative studies with physicians where they really felt unprepared in many cases to address the increasing number of patients that were asking them about the evidence. So we undertook a systematic review in order to inform a clinical practice guideline, which has just been published in the British Medical Journal. And we found 32 randomized control trials, not large in size, that have explored different types of medicinal cannabis for the express purpose of helping people living with chronic pain. We also reviewed a number of observational studies to look at long-term and infrequent harms. We also reviewed evidence if providing medical cannabis might help reduce the amount of opioids that patients are taking. And we did a review looking at patients' values and preferences. And what we found was reasonably good evidence, actually, that medicinal cannabis versus placebo can provide a small benefit for pain relief and for sleep quality, a very small benefit in physical functioning, and no benefit, it seems, for emotional functioning, mental functioning, or role functioning. And when I say a small benefit, what do I mean? Versus placebo, you will get an additional 10% of patients living with chronic pain that experience a degree of pain relief that they'll report as important. So that means you have to treat 10 patients with cannabis versus placebo for one to report an important benefit. This is not a large effect. However, if you look at another very commonly used medication for chronic pain like opioids, there you have to treat 8 patients to get one that achieves a reasonable benefit on pain relief. So they're not that different. What about the side effects? Well, we did find good quality evidence that there is a small increase in risk of transient harms, things like nausea, sedation, low degrees of cognitive impairment, slightly higher risk of dizziness, which increases the longer people are on treatment with cannabis. But again, these are typically considered to be more mild adverse events for patients that in many cases they're willing to tolerate if they are achieving some benefit. When you look at some of the harms that we're more concerned about, early onset psychosis, suicidal ideation, or even suicide attempts, motor vehicle accidents, falls causing injury, we unfortunately have very poor evidence. We're uncertain about the increase in risk associated with use of medicinal cannabis. That may seem unusual for people to hear because we do hear about the association, for example, with early onset psychosis or risk of cannabis use disorder. But this evidence largely comes, in fact, entirely comes from studies that have looked at recreational use of cannabis, inhaled products, high levels of THC, the kinds of products that would not be used therapeutically and that our guideline does not get into.
So you mentioned that medicinal cannabis may have different benefits, side effects, but particularly you mentioned one of the things that you had looked at was cannabis versus opioids, another medicine used for chronic pain and one that's been shown in recent years to have more side effects. Maybe let's debrief a little bit more about what some of the potential benefits of cannabis might be in comparison or contrast with opioids for chronic pain.
Yeah, well, it's a question that a lot of people are debating right now. And in fact, there's some states in the US that have passed legislature encouraging the use of medicinal cannabis as a way to substitute for opioids. So opioids are very commonly prescribed for chronic pain, particularly in North America. About 1 out of every 3 chronic pain patients in North America will have received a prescription for opioids. And as you alluded, we have become increasingly aware that the benefits are not as great as we had hoped. and that there is a risk of serious, sometimes catastrophic harms, including addiction, overdose, and even death. So there is an interest in trying to find medications that might be similarly effective, but have less of a harm profile. And so there have been studies looking at whether or not cannabis, when provided to chronic pain patients using opioids, might allow them to reduce their dose. A recent guideline came out from the UK NICE organization in 2019, and they actually concluded that there was no impact of providing cannabis on reducing the amount of opioids patients used. However, there was an important limitation to that finding. The studies that they looked at, which were either 4 or 5 randomized controlled trials, they all instructed enrolled patients not to change their dose of opioids. So it's not really a surprise that at the end of the study, no one had changed their dose of opioids. We acknowledge those studies, but we acknowledge that that limitation is so severe that it provides us with no credible information as to the possible role of substitution that you might see with providing cannabis. We then looked at observational studies, which are weaker in design. They're unblinded. They don't have a control group. The observational studies did suggest that if you provide access to medical cannabis, patients that are prescribed opioids for their chronic pain can reduce their amount by over 20 milligrams morphine equivalent per day, which is a substantial reduction. These are observational studies. So again, we assign that finding a very low credibility at this point. So we need more evidence to know. There is absolutely a lot of anecdotal experience. There are observational studies from the US before and after they made cannabis available that seems to suggest some patients do substitute opioids for cannabis when it becomes available. And this should be a priority area for future research.
Yeah, I guess we don't want to just substitute one medication with a lot of potential side effects for another. So it sounds like it needs more study, but there's, it's a potentially encouraging, given the nature of how severe some of the opioid crisis is in North America. As you say, this would be a priority area for more research to see if there's a safer option for people suffering from chronic pain.
Yeah, and the one thing we know about cannabis is you can overdose, but you can't fatally overdose. And unfortunately, you can do so with opioids.
So you mentioned that in some of your research and the systematic review of studies, that you also looked not just at some of the potential benefits, but also side effects. So what are some of the potential side effects and or risks associated with cannabis or cannabinoids used for medical purposes in the treatment of chronic pain specifically?
Yeah, and I'm glad you made that distinction, used for medical purposes. We have a lot of literature on the harms associated with recreational use of cannabis. Again, typically inhaled, typically high levels of THC. And there we absolutely see things like, cannabis hyperemesis syndrome, where people report to the emergency department great distress. We do see overdosing. We do see increased risk of car accidents. When it comes to medical cannabis, we have much less literature to look at. From the randomized controlled trials, we absolutely see small increases in risk. What do I mean by small? 2 to 5% increase in the risk of things like nausea or sedation or limited cognitive impairment. Dizziness seems to affect close to an extra 10% of patients that are trialed on cannabis versus placebo. And that number goes up to close to 30% when they are on that product for 3 months or longer from the studies we have. When we look at the evidence for the serious adverse events, that's where we just don't have enough to make any concrete statement. So we need those kinds of studies to be done. For example, there is a hypothesis that because use of cannabis containing THC can elevate heart rate for a brief period of time, it could be associated with an increased risk of cardiac events. But unfortunately, we just don't have enough evidence to be sure about that. So it's an area of potential caution, but we don't know what the actual risk is. In our guideline, for example, looking at another area, we know that THC can have an impact on the developing fetus. We therefore have made recommendations that women that are planning to become pregnant or are breastfeeding do not consider medical cannabis for dealing with chronic pain. Again, we don't have concrete evidence on the specific effects of medicinal cannabis, but because we know there is an association with adverse events and recreational cannabis, we've erred on the side of caution.
I think it's good just to highlight the differences, as you said, between medical cannabis authorized for a particular condition versus recreational cannabis. And in your research and your review of the studies, you and your guideline, you did not look at any inhaled products, and I think that's just important to keep in mind in terms of lung health and lower risk cannabis use guidelines. People are pretty clear that inhaled cannabis carries with it pretty serious health risks in terms of lung health.
Well, and it's interesting. We wanted to look at inhaled medicinal cannabis. None of the trials that have been published that met eligibility criteria have administered inhaled cannabis, probably for the reasons that you just highlight. If you can take a therapeutic product through ingestion or topically, why would you inhale it, right? I mean, we give people fentanyl patches. We don't encourage them to, roll up a patch and inhale it through burning it because of the pulmonary harms. So one of the questions that I certainly have after looking at the evidence and looking at what people are using in the real world in Canada, why are so many patients using inhaled cannabis products to manage their chronic pain when the evidence really only concerns non-inhaled products? And clearly it seems obvious that you are going to take an additional burden of harm by inhaling cannabis versus taking it orally or even topically. So I think there's an important disconnect out there that needs to be resolved so that if patients are interested in looking at this therapeutic alternative, it is made available in a format that is more likely to be safer and deliver similar effectiveness.
So you mentioned that in your review of the research, one of the guideline recommendations was that people who are pregnant or planning to become pregnant should avoid medicinal cannabis. Are there any other people or special populations that should avoid thinking about a trial of cannabis for the treatment of chronic pain?
Yeah, and to some degree, it depends on what type of product you're looking at. So CBD, cannabidiol, the non-psychoactive cannabinoid, that's been used at extremely high levels, for example, in trials of pediatric epilepsy, as much as 50 milligrams per kilogram per day. So we're looking at enormous doses that you wouldn't get into with chronic pain. So the safety profile of CBD appears very good. THC is different. THC is the psychoactive component. That's the one that we get worried about with potentially having an association with early onset psychosis, with perhaps resulting in the development of a cannabis use disorder, with causing that euphoria that might result in increased risk of falls, motor vehicle accidents, might exacerbate other underlying mental illnesses. So we have suggested that practitioners and patients interested in looking at a trial of medical cannabis do look at high CBD products to start. Only if there is not an adequate response that they then consider adding on some level of THC, doing so gradually to assess the response and the tolerability to adverse events. We've raised particular cautions around the use of medical cannabis in pediatric and emerging populations, particularly because the association between effects on neurocognitive development and perhaps with triggering early onset psychosis are uncertain, but they are a potential. So that would be another category to carefully consider. And individuals that had active substance use disorders or history of substance use disorder, we know with many other psychotropic substances such as opioids, they are at higher risk for poor outcomes, including a use disorder or even an overdose. We don't have that kind of evidence yet for medical cannabis, but it would not be unreasonable to have an elevated level of concern when considering patients coming in with those kinds of features. And we have to be very cautious and humble about what we don't know. We can't get ahead of ourselves by making statements that the evidence is later going to prove us wrong on. The other challenge that we have with medicinal cannabis is it is so available at this point. It is so easy to access. The Health Canada numbers alone, looking at those patients that have been authorized to use medicinal cannabis, suggest it's about 500,000 Canadians at this point. And that number has been just skyrocketing year after year. The Veterans Affairs Canada last year reimbursed over $100 million for medicinal use of cannabis by veterans. That has gone up from, it was maybe a few $1,000s a decade ago. So we're seeing incredible increases in use. And we know from surveying patients in the community, a lot of individuals are using these products without medical authorization, suggesting the true number is much higher. So there's a lot of uncertainty, and that's frustrating for patients and clinicians. But the rate of use is so substantial that the research is urgent to do so that we can better understand who might be an appropriate candidate for a trial of cannabis and who really should stay away from this product because of underlying risk factors they have that are going to put them at a higher chance of having a poor outcome or negligible benefits.
Can you maybe explain what constitutes a weak recommendation exactly?
Yeah, this is a really important concept. So we use something called the GRADE approach in order to formulate the recommendations for the guideline. In this case, the single recommendation. And it is a weak recommendation. A strong recommendation means that basically all informed patients would make the same decision. A weak recommendation means while we believe the majority of patients who are dealing with chronic pain that is not well addressed by standard care would agree to a trial of cannabis, an appreciable minority would not. And that's because we have a very close trade-off between the benefits and the harms. There is the possibility for a minority of patients that they will experience some benefits to physical functioning, to pain relief, and sleep quality. We also know there's a small risk that they may experience a number of transient adverse events. This means that different patients, given the same information, are going to make different decisions. So a weak recommendation means it depends on the patient in front of you. The best strategy is to engage them in shared decision-making, provide them with the evidence on benefits and harms, and help them to make a decision consistent with their values and preferences. To facilitate this, we have published our guideline on an online platform called the Magic App, which allows us to produce patient decision aids. Anyone with an internet access can access the site, review these documents, provide them to patients to hopefully help them in making the decision that's going to be right for them.